Hello, good day. Welcome to the Utah Dental Association Continuing Education Lectures online. My name is Dr. Jeremy Manwaring. I am a local periodontist here. I practice in Salt Lake City, Park City, Utah. A little bit about myself. I grew up in Utah, and I went to the University of Utah for undergraduate studies, and then I went to Northwestern University Dental School for 2 years because unfortunately they closed after 2 years, and then I finished up my dental school at Tufts University of Dental Medicine in Boston University. And then because of that big move, we decided to stick around and stay in Boston, and I was able to finish up with a periodontal certificate after 3 years and a master's, all from Tufts University School of Dental Medicine. It's my privilege and pleasure to chat with you today regarding soft tissue management, something near and dear to my heart. I'm a periodontist, and I should also mention too, I was also a hygienist. That was how I worked my way through dental school. I was able to take the hygiene boards and was a hygienist on nights and weekends, helped me pay for dental school. So I am a true hygienist, a true periodontist, and I love soft tissue, and I'd like to talk to you a little bit about it today. Again, if you have any questions and concerns, and I'll give my information now, and again at the end, please feel free to reach out and chat with me. Our practice is called Redwood Periodontics. Again, we're in Salt Lake and Park City, and our office phone number is 801-293-8833. Let's get started. Let's talk a little bit about soft tissue. I am a practicing periodontist. So instead of giving you slides of classifications of different recession and what to do, I'd like to show you some cases. I'd like to get right into it. If you're a little squeamish and don't like the sight of blood, this may not be the lecture for you. Sorry about that. We're going to do some surgery together, and we have some suction, and we're going to have some clean slides, but we're going to get right into it. But glad to have you here. Again, this is a great opportunity for us dentists in Utah to have some online continuing ed. Let's talk about recession. Let's talk about it first. And I'm going to pull up this first slide so we can use a patient as an example. Patient walks into your office and mentions probably this case. This was a 24-year-old female who was quite concerned with the recession on her 2 front teeth. Well, right off the bat, I'd like to tell patients that recession, the primary cause of recession is genetics. People are a little confused about that. But once I mention the primary cause of recession around teeth is genetics, a lot of them will very instinctively say, you know what, my mom has this, or my sister had to have a graft, whatever. They recognize that. A lot of people think that recession comes from overbrushing, comes from tooth movement, comes from grinding, clenching habits. Those are all secondary causes of recession. Primary cause, again, is genetics. Let's look at this sweet gal and help explain it a little bit more. I'm going to use my mouse, and we're going to trace the mucogingival junction, because this is what I'll tell patients. They won't understand what a mucogingival junction is. Let me back up and how I explain it to a patient. I'll say, hey, there are 2 types of gum tissue in our mouth. There's soft gum tissue and there's hard gum tissue. The hard gum tissue we call attached. It's like the gum tissue on the roof of the mouth. That stuff doesn't move. It is hard. You can bounce a potato chip. You can bounce a crunchy granola bar off the roof of your mouth. You might scrape it, but it doesn't hurt. It's hard, it's attached. Well, the soft gum tissue is the lining of our cheeks and our lips. That's very fragile. It can bleed easily. It can have canker sores, and it's a terrible margin around teeth. This gal didn't have the problem, but a lot of even adolescents will come in, and because of that lack of that thick, healthy keratinized tissue, if they've got a mucosal junction, mucosal margin on the edge of their teeth, it would become red, fiery, inflamed, and a lot of people subconsciously, I'll show you in a future slide here, will actually skip brushing that area because it hurt too much. And it'll collect plaque, therefore it gets worse. It's kind of a vicious cycle. Well, this case, she has a little bit of everything showing. Let's talk about it. I also would tell a patient that every spot, every tooth that has recession does not necessarily need a graft. It just doesn't. If indeed you've got a little zone of recession, but have an adequate zone, and we'll show you in this case, of thick keratinized tissue, and it's not sensitive or a cosmetic issue, then it doesn't necessarily need a graft. But a lot of us are walking around with a little bit of recession. If we've got a good zone of keratinized tissue, really, and again, it's not sensitive, and you've got good oral hygiene, and it's not in a cosmetic region, you'll probably be okay. However, what we worry about as periodontists and as dentists is that if you've got recession, and even if it doesn't have sensitivity or in a cosmetic area, but they have very little or no keratinized tissue, we're worried about the foundation of these teeth. We're worried that in time that will continue to recede because the mucosal tissue is a terrible barrier around teeth. It will continue to recede once it hits the mucosa. So let's go into this case together. Here's the mucogingival junction. You can see, first of all, this gal debunks the myth that you brush too hard. Well, look at 8 and 9 have recession, 7 and a repositioned 11 do not have recession. It's very, very hard to brush 2 front teeth and skip the ones right next to it. Brushing your teeth is not the primary cause of recession. It's genetics. It's genetics. Again, as we see here, we've got a good zone of keratinized tissue around this lateral. And as we trace it, here's again that you can show the patient the mucogingival junction right in, obviously using a mirror, but in their own mouth. In the mandible, I'll show you in a second, it jumps out a little bit more than the maxilla, but in the mandible, you can really see it. Here's her line right here, and you can show them, here's the thin gum tissue, you can see blood vessels, we can move it, you can move their lip back and forth, that'll go up and down. This tissue will not move. And I love to show them, give them the mirror, and show them exactly the difference between the hard and the soft gum tissue. Well, this gal has very little keratinized tissue on the front of these 2 teeth. They were sensitive, and also she didn't like the cosmetic appearance of it. Also, if you take your periodontal probe and put it right here in the sulcus, you're going to probe right up to that mucosal tissue. You can almost see the probe because that gum tissue is so thin here. So what we recommended for this sweet patient was to do what's called a connective tissue graft. Now I'm going to show you 3 types of soft tissue grafts in this little lecture. First, we're going to show you the connective tissue. The connective tissue comes from the internal surface of the palate. It doesn't come from the epithelial tissue. It comes from what is underneath. And I'm going to show you that very specifically in just a moment. That's called the connective tissue graft. It's also called the subepithelial connective tissue graft, meaning underneath the surface. The second type of graft that I'd like to show you is the free gingival graft. This is the more historic graft that you've heard of a million times. It's been going on for many, many, many years. And that's when they take the surface of the palate. Now that's a little more uncomfortable, as you can tell, and we'll talk about it. It's pretty obvious why it hurts. And then the third type of tissue graft that we're going to talk about is a donated tissue graft with cadaver. And we'll talk about the advantages and disadvantages once we get to that case. Let's talk about the connective tissue graft. In our practice, this is what we use the most. It's the most comfortable of the patient donated tissue. Clarify that. And we actually get the best result. With a connective tissue graft, you can cover up the recession and augment the keratinized tissue in this area. Let's get right into it. First of all, what we do surgically is we are going to do a split thickness flap and reflect up the tissue that is overlining these teeth. Let's show you that now. With 2 vertical incisions, and everybody's got a little different technique. Sometimes we don't use the verticals. Most of the techniques work very well. This is the type that we used this particular day. 2 vertical incisions and a 2 straight incisions are then placed across the front of these teeth. You'll see there are 2 parallel incisions. We will de-epithelialize between these 2 incisions. Better to show you. The split thickness flap is then reflected and moved out of the way. It is a split thickness flap because we like to keep the periosteum or the gum tissue, a thin layer of tissue, a thin bed of tissue, still is on top of the bone here. So this is not a full thickness flap. What you're seeing here is not bone, but gum tissue. And then we are taking out the little epithelial wedge, if you will, keeping the tips of this papilla intact. What we also like to do, and there's many different ways to do that, but in order to help the gum tissue adhere better to the teeth and to the root surface, we will cleanse the surface of the recessed areas. Now you can also tell a lot more recession is present once we've reflected that flat back than what we had clinically. And so you can see, and in subsequent slides, I'll show you that it really is the case. So a lot more recession than we thought. We will etch the surface. There's a lot of different cleansing products that are out there to etch the surface of these teeth. You can use ultrasonic or hand instruments to clean the surface of this, but we do like to clean the surface. It's been exposed, at least some of this recession has been exposed to the oral cavity for quite a while, and so we like to clean that surface. Now let's go to the roof of the mouth. I should also mention, before I even show you this next slide, that everybody that comes out of our office, and in most offices that do connective or soft tissue grafts, leaves the office with what we call a stent. It looks like a guard. It's usually an acrylic or a suck down type of acrylic that is then placed immediately after the procedure and protects the roof of the mouth like a Band-Aid. Looks like an orthodontic appliance, but without teeth on it. A clear stent is what we call it. We make one for every patient. Very simple to make. Patients usually will wear it. Everybody's a little different. Usually wear it about 2-3 days. After 2 or 3 days, they don't need it. It's like a Band-Aid. It's just like if you had a Band-Aid on your hand. After a couple of days, you just don't need it. It feels good to take out. I should also talk to you a little bit. We give all of our patients a couple of prescriptions prior to this procedure. One is for a simple antibiotic. We're doing a procedure in a very non-sterile area. We like to put them on an antibiotic just to ensure that we don't get infected. We also give the patient an anti-inflammatory, which acts also as a good pain reliever. Something as simple as naproxen or ibuprofen, Aleve or Advil, works very, very well. And most patients, I dare say the majority, over 50% of patients, that is all they need for pain management, is a little ibuprofen. We can also tell patients to add a little Tylenol to it as well. Now, there are a few patients, and it's not a big deal, but we will prescribe a little narcotic, Lortab, Norco, Percocet, 5 to 6 tablets for somebody that undergoes this procedure, depending on their level of. But most people, again, most people stick with the ibuprofen, the naproxen, and ice. Really, we're big fans of ice. So for about 6 hours after the procedure, we ask patients to sip on ice. Get a glass of ice water and just sip on it. Anyways, I tell you all of this before we go to the roof of the mouth. As you can imagine, the actual recipient site, or what you can see here, the facial aspect of these teeth, the discomfort's not too bad. It's the roof of the mouth, unfortunately, that is a little exposed. And therefore, we have the guard, we have them start the anti-inflammatories, the antibiotics, everything is started. We like the day of, or even an hour before. It really helps out quite a bit. Let's go to the roof of the mouth. First of all, a straight incision is made. So in the connective tissue graft, when we're done, I won't show you a picture of it, but when we're done, this is what the roof of the mouth looks like. Now there's a few stitches that crisscross this just to hold this in, but this is just a straight line. Because in the connective tissue graft, we're not taking the superficial tissue. Here it is. So a straight line incision is done, just like I showed you. And then we are splitting the gum tissue, creating two different layers. This is the underlining connective tissue you can see with my mouse. And here is the overlining epithelial tissue that after this procedure is done will then be placed right back. Again, not an open sore like the traditional free gingival graft. And I'll show you a picture of that when we get to a case that involves the free gingival graft. Here is the underlining connective tissue graft. This tissue then is removed and the overlining epithelial flap is then put right back into place. And then a guard is immediately put in there afterwards to protect that. So the patient will not feel an open sore, but a patient will feel a dip in that area. It feels a little bit smooth. Just so you can tell your patients, typically this takes about 2 to 3 months to regenerate. After 2 to 3 months, you can actually go back to the exact same site and get the exact same piece of donor tissue. It has grown back 100%. You can tell them that. I usually say, I'm going to borrow a little tissue from the roof of the mouth because we are borrowing because it comes right back. Anyways, we take that gum tissue. I'll let you look at that picture long enough. There it is, laying on a piece of gauze. It's only out of the mouth for 5 to 10 seconds because we prepare the recipient site first. Again, here's the graft being laid into place. First of all, we will suture and stabilize, and I'll show you in the next slide, but we'll suture and stabilize the graft without worrying about the overlying flap first. Now don't worry, we do place the graft slightly above the CEJ. Brings me to a quick discussion. Connective tissue graft will never adhere to enamel. It will never adhere to a foreign substance, such as composite, porcelain, a gold crown, or an implant. We'll talk about that down the line a little bit too. So what will happen, even though we place this tissue just slightly above the CEJ on the tooth, it will shrink back and then shrink back to the CEJ, therefore covering all of the recession. Let me show you, this is stabilized with dissolvable stitches. The graft is first stabilized through the papilla with the dissolvable stitches, and then with dissolvable stitches, we suture the split thickness flap over the top of the graft up to this new position. So the connective tissue graft works so well to cover up the recession, but also to augment this tissue because it has two forms of blood supply. One coming from that thin bed of tissue that was left on the bone from the split thickness flap, and second of all, from the overlining flap that goes on top of it. Two sources of blood supply for this graft. Therefore, it is a very successful procedure, and success rate is high 90s. Can never say 100%, would be lying, but very high 90s, even in smokers and diabetics. That's why this is kind of our go-to procedure. And in our office particularly, we use this procedure 80–90% of the time when dealing with recession because it is so successful. Let's keep talking. So again, we have covered up the recession. We've also covered a little bit of the enamel. We know full well that this will shrink back to our CEJ when we're all done. Let's go to our next slide. Here is 8 weeks later. Now, first of all, good healing, but sometimes this gum tissue will appear a bit bulky. A little bit of scar tissue may be forming. Now, if it's in a non-aesthetic area of the mouth, we're pretty much done at this point. However, in the aesthetic zone, what I'll do, here's our next slide, I'll take a small, thin, round diamond burr and blend in and get rid of the bulkiness. I'll also get rid of the little vertical incisions that sometimes can form a little scar there, all to blend this in better. You allow that to heal up really a week or two, and here she comes back. This is the final result after 1 year. The next slide, I'll show a before and after, but I want to point out a few things here on this slide. First of all, we've covered up the recession. The dentin, the root surface, the cementum is covered up. Sensitivity, therefore, pretty much vanishes very quickly with these patients. Second of all, cosmetic result. She's happy about it. Now, most important, and I have to emphasize this to our patients, most important, we like the thick zone of keratinized tissue that is now present. If you look close, and as I trace it with my arrow here, my mouse arrow, you can see here is the new line, the mucogingival junction. Much higher. Now, if you probe, a lot of people say, well, hey, if I probe this area, am I going to get a 6 millimeter, 7 millimeter pocket going right back up to where I started? The answer is no. When you probe this area, you'll get a 2-3 millimeter pocket. It's healthy, it's sound. She should have this for really the rest of her life. She's got good hygiene. You can tell how well everything's healed up. We'll show you down the line a few patients that don't have such good hygiene, and this graft actually even works in the poor hygiene. This gal's got great, excellent hygiene. We know this is going to be a long, healthy, aesthetic result for her for many, many years to come. Let me show you the before and the after. Again, two things when we look at the before. 4 to 5 millimeters of recession. You can see she's got just a severe lack of keratinized tissue on the buccal aspects of 8 and 9. A connective tissue graft is placed, and now you can see how healthy and thick that gum tissue is. Bulky, thicker. If it's too bulky, again, we can smooth it back a little bit, but this is just a great result for a very sweet patient of ours. Let's keep talking about different sites of recession that we see. This is probably the most common. Easier to take pictures on the top with doing surgery, so that's why we did the elongated case up top. I'll show you a few surgical sites here on the bottom. But the majority of recession that we see in our office is 24 and 25, just like you can see here on the screen. And if you look close here, you can see the mucogingival junction. Again, much easier to point out on the mandible, especially in this patient. If you look close, here's the mucogingival junction coming across here. When we hit this 20, looks like 25, you can see almost a pouch is formed. And if any of you have seen these in the mouth, you'll see there's that mucosal tissue, when it gets inflamed, actually forms a little pouch. There's always a little plaque in there because the patient almost will skip that brushing. As they brush, they skip right over the top of that, keep going. Not a great place to become fiery and red. And our adolescents patients, will see them come in and say, oh, it just hurts so bad. Well, we know they just have a lack of keratinized tissue. Immediate treatment is as simple as giving them a prescription for some chlorhexidine, some Paradex, Periogard, whatever it could be called in your pharmacy, but chlorhexidine. Have them pour some of that chlorhexidine in a cap and dip a Q-tip in the cap, get it very saturated, and then dab that area. That will absolutely help immediate discomfort. It won't grow gum tissue back, but it'll help that mucosal tissue become much less inflamed. So start off with that. However, we noticed that in this patient, she is going to need a soft tissue graft to augment this tissue. Now here is what's interesting. We talked about secondary causes. Braces did not cause this. This is genetics. A lot of times the orthodontist is somebody who can see it first and alarm the patient to what is happening. Many times some orthodontists will actually stop treatment so we can fix it because they're worried it's going to have even more recession. Well, again, orthodontics does not cause recession. Blankly, it just doesn't. It can contribute, but it surely doesn't cause it. However, what I want you to notice in this next slide, we're going to do the same thing. We're going to release this flap, do a split thickness flap. And as you notice here, much more recession is present than we thought. Now, a lot of times we'll say, hey, why don't we do, or a lot of people ask, why don't you do a bone graft? It looks like these teeth are out of the bone. Well, again, going back to our discussion that we had regarding nutrition or blood supply. A bone graft, just like a connective tissue graft, needs blood supply. Well, if we were to put bone on the top of these teeth, a bone graft, it's not going to get much blood supply. These teeth will not bleed. They're not going to help the bone graft at all. And a bone graft really is not very effective for growing a buccal plate on front of teeth. Now, Not that, and so therefore the second best thing to do, if you could do a bone graft grape, the second best thing to do is thicken up that gum tissue with keratinized, thick, attached gum tissue attached to these roots. Now, a little experiment you can do, you can put your finger, and if you feel underneath your lip, put your finger on top of your canines. Most of those don't have a lot of buccal plate on the top. Most of our canines, if you think about it and if you palpate it, are very, very thin. The bone, if not present. However, if you have that good thick zone, keratinized tissue, it's not a problem. However, let's talk about this. So we are going to then, just like we mentioned before, we're going to go to the roof of the mouth, and we'll borrow some connective tissue and place it right over the top of these. Here it is. If you noticed, you may have noticed the last connective tissue graph show you with a different color. Everybody's a little different. This may have had a little more epinephrine in it. Some people's tissue has a little more adipose tissue. As you can tell here, we typically don't trim it off. If it's excessive, we'll trim a little bit off. But again, this connective tissue graft then is laid on top of the facial aspect. It is then sutured in, stabilized, just like we talked about before, and then this flap then is brought up and over the top of this graft. There it is the day of. Now again, it looks perhaps even messy, if you will. The tissue is pulled up over the CEJ. We want to make sure that this graft, the donated tissue, is completely covered up. And we want to give it as much blood supply as we can to help it attach and form. Let's go to the next picture. Here's the before and the after. Again, here's that little pouch we talked about that's very prevalent, especially in young kids. And as I remember, this sweet gal was 14 years old. I am pulling on this tissue pretty significantly, so that's why this tissue is white, and why I want you to see where that white is. That is the new mucogingival junction that has reestablished itself on the front of these teeth. Obviously, braces have been taken out, taken off, and now we've got a great, thick, healthy zone of keratinized tissue that will be very, very long lasting. Good brushing, good flossing. This person, nobody will ever know. I tell patients, hopefully you just forget about me. You'll never know that you ever had this this graft done. And hopefully in the future, with the connective tissue graft, not even the dentist will tell that you had it done, which is great because it's your own tissue. One other kind of contributing factor, again, we talked about orthodontics perhaps being a contributing factor, but not the primary cause, frenums. People with high frenum attachments, as you can see in this picture, sometimes, first of all, that brings a lot of mucosal tissue there, right? Because a frenum is in mucosal tissue. But you can absolutely see that on the facial aspect of this tooth, there's almost, well, there's no keratinized tissue. You can see the root, you can see the little blood vessel. This is all mucosal tissue associated with a high frenum line in this area. Well, the concern is, and a lot of people will say, hey, let's just do a little frenectomy. Well, that may get rid of the frenum, but it sure doesn't augment the mucosal, that doesn't augment the tissue whatsoever. You still will most likely get recession in the future. The frenum is a contributing factor, but not, again, the primary cause. However, what we do then, when we release that flap, just like I've showed in the last two surgical series, we do an internal frenectomy, if you will. So we're not cutting it from the outside, we're cutting it from underneath, therefore releasing those little elastic fibers. Patients are worried, is my lip gonna fall off? We explain now. The frenum attachment does not hold your lip up. You won't have a droopy lip. Anyways, sometimes you have to explain that a little bit. But we do an internal frenectomy, place a connective tissue graft, and that frenum may reattach itself. Let me show you in this next picture. Again, here's the before, here's the after. The frenum reattaches itself, but now that you've got a zone of healthy, thick, keratinized tissue, it will reattach itself at a much more apical position, therefore not causing a problem whatsoever. Again, frenum's not the issue, but it's the lack of keratinized tissue that she had beforehand. Now you can see that thick, healthy gum tissue. You know this is going to be a great long-term case, even after orthodontics. You can tell some orthodontic movement has happened while this surgery and treatment plan had been carried out. Now, quick answer to a question we have: when to do a connective tissue graft if you notice issues and you're getting ready to do orthodontics. Well, ideally, from a periodontal standpoint, we'd love to do it before you place braces on. Therefore, you won't have any concern as teeth are moved. You've got a good thick zone of keratinized tissue. However, we can do braces. We can do a soft tissue graft before orthodontics, during orthodontics, as you can see here in this picture, or afterwards. Really doesn't matter. Ideally, it'd be nice to do before. The less recession you have, the better result you're going to get. So it's great to identify the cases that have very thin keratinized tissue or no keratinized tissue on the front of, usually again, 24, 25, before braces. We can thicken that gum tissue up afterwards. Orthodontics isn't a problem at all. Now, another contributing factor, not primary factor to recession, is bruxism, clenching and grinding. You can see this patient, boy, has flattened that canine right off. This is great. Well, two things we will recommend for this patient. First of all, a night guard. You can do a beautiful graft for an individual, but if they continue to grind and clench just like this older gentleman did, this is probably the only case of recurrent recession we'll find is when they continue to grind or clench their teeth. So again, a night guard is essential, and then a connective tissue graft, again, just was placed just like we've shown in the previous couple of slides. And here's your result afterwards. Covering up that root, thickening it up. Again, even if he does grind but doesn't wear his night guard, at least he's got a thicker zone there that will be much more sturdy than if he didn't. But again, a night guard is essential to not have recession in this area. Let me talk to you about multiple teeth, and let me talk to you about a patient who's got some less than ideal hygiene. Now, obviously, hygiene is super important with all these, but as you can see, as we look at this young man's mouth, he's got a little bit of plaque right along these edges. Not a great home care guy. Needs a good education by you and your hygienist of how to brush a little bit better. But what was also starting to happen, the dentist was worried about decay on the root surfaces here. And he was worried that he may have to do some classify fillings. Anyways, we instructed him that let's do the connective tissue graft, and here's the before, here's the afterwards. You can see that he still doesn't have the best hygiene, but now that we have covered up the root surfaces, we're less likely to get cavities on those surfaces which are much more porous. Again, we'd rather not have plaque anywhere, but if we have to have plaque, we'd rather at least have it on enamel. Which brings me to another point. If indeed we do start to see some incipient lesions, and then this I want to talk to you about this case. This was a very small carious lesion, very superficial. And instead of putting a class 5 restoration on the top of this lesion, what we elected to do was to smooth off the incipient lesion just with a light diamond burr, get down to some good healthy root surface, and then do a connective tissue graft over the top of it. Well, many times if that cavity is very significant, if it's significant, then you do need to do a class 5 restoration and or crown, whatever is needed. But if it's just an incipient little lesion, better to smooth that off, do a connective tissue graft over the top of it, and put a tissue filling, if you will, over the top of that. That'll remain healthy and sound for many, many years to come. Now again, I gave you a sneak peek of this next slide. I'm practicing periodontist. These slides are on current patients. These weren't done in dental school. This is something that we're doing right now. Here is something that came in the other day. A clinician had placed a restoration, a finger, if you will, down the mesial root, and the margin of the restoration was in mucosal tissue. This became almost an immediate irritant to the patient. Every time they brushed it, it was irritating. A great spot for recurrent decay. So we're pretty worried about this having recurrent decay in the future. So ideally, and again, I don't have any more finals. I just wanted to put this up really quick. Ideally, what we would have recommended firsthand You still may need to do some, so even if the decay is significant enough, you need to do this size of restoration. Ideally, what we would have recommended is to have that margin in keratinized tissue rather than in mucosal tissue. We much rather have margins of restorations in keratinized tissue. They're easier to maintain, less chance of recurrent decay, they look better, and just healthier all around. So ideally, if you do have some deep decay, and it looks like you're going to have to do a class 5 restoration and or some sort of crown, we would recommend placing connective tissue graft, augmenting that tissue to thicken it up, and then putting a margin in good, healthy, strong keratinized tissue. Just a quick little interesting case that came in the other day. This patient had an impression cord that was left in, or had an allergic reaction actually to the impression cord. This all happened within 24 hours. Patient came in and it had receded fast enough that a little bone was showing. Well, great. We jumped on it really quick, put a connective tissue graft, covered it all up, and we're able to bring that gum tissue back down to the margin of the crown. Now, again, if you're a hygienist or a dentist, we definitely need to help this gal out with some hygiene. But we were able to save that tooth by doing a quick connective tissue graft. We'll work on her hygiene now. Let's talk a little bit now about the second type of graft that I mentioned before, which is the free gingival graft. Free gingival graft has been around for decades. My father was a periodontist. This is one of the things he learned in dental school once upon a time. They've been doing free gingival grafts for many, many years. They're very successful. However, anybody, dentist or patient, can recognize when a free gingival graft was done. And you'll see, we're going to show you one right now. They're bulky. They're definitely not a cosmetic result. We're not pleased with the aesthetics of the free gingival graft, except in the case of young adolescents. We will do a free gingival graft with young children. They pretty much blend in over a couple of years as they continue to grow. So that's the one time, and it's a good time to do a free gingival graft. Well, this is just such a case. A young girl had braces taken off, and this was the result afterwards. Parents, dentists, orthodontists were all worried about how thin the buccal tissue was on the front of these mandibular anterior teeth. You can see zero keratinized tissue here. This is all mucosal tissue. So if we did nothing, guarantee that these two teeth, and maybe even the ones on the side, the adjacent teeth would start, and then we have significant issues. Well, because this person was young, and because this is a non-aesthetic area, we elected to do the free gingival graft. Again, everybody that leaves our office, before I show you the next slide, does have a guard. Here's the next. Well, here's the close-up. You can just see how thin this gum tissue is. We need to do something or we're in trouble. Well, we reflected the flap and noticed a little bit more recession than we had originally thought in this area. Again, here is the tissue that we did a split thickness flap and reflected this tissue. Now in this, the free gingival graft, this tissue is just trimmed, even just left to resorb. It'll resorb right away. The graft is then placed right on the front. Here it is in its donor site. You can tell that's much more uncomfortable. Again, a guard is placed right on the top of that. Sometimes we'll put a little collagen strip in there to help facilitate some hemostasis and create a little quicker healing. I'll get rid of that slide quick because it makes me uncomfortable too. But here's the post-operative result of a free gingival graft. Now we call this a brick wall. This is a graft that this individual will have for many, many years, their entire life. You can sure see where it is. Luckily, it's in a knot. She had a smile line that never ever showed it. It's something that'll just be there the rest of her life. Again, in this young age, I would anticipate this will actually start to blend in over time. But this is a brick wall. This is healthy. Again, we wish we had bone in front of these teeth. This is the second best option because a bone graft just wouldn't be that successful on top of these teeth. Well, great. This free gingival graft will be strong and healthy for many years to come. Again, that's the free gingival graft, if you will. There's the before. Again, thin mucosal tissue. There's a thick free gingival graft done afterwards. Now, I'd like to show you a case of donated cadaver tissue. There's a lot of different products out there that that are marketed for tissue grafts. The one that we use in this case is Alloderm. I'm not paid by Alloderm. This is just what we use. That's just a type of tissue that we'll use from a tissue bank. Well, let me show you this. The procedure is just a little bit different. We will call this, I'm going to click forward here. We call this papilla retained pouch technique, if you will. That's a long way of saying a tunnel technique. It's also been called the pinhole technique. There's a lot of different this technique has been around for many, many years. Recently, it's much more popular with certain dentists out there, and it's great because it's all thickening up gum tissue. However, in this case, what we're electing to do, instead of releasing these papilla, like I've showed in the other couple surgical slides, we are going to keep these papilla completely intact, and we're going to slide in cadaver tissue to augment this tissue. Now, the reasons why to use cadaver tissue. First of all, if you're doing multiple teeth, a large area, the human palate just isn't big enough to accommodate many, many teeth if you want to get it all done at once. That's a very simple fact. Also, and the very obvious reason to use it is comfort-wise. In our practice, we tend not to use the cadaver tissue with people who are compromised medically, diabetes, even smokers, because the connective tissue graft works so very well that we usually elect to use their own tissue. Again, that doesn't mean that the donor tissue doesn't work, but in our practice, we tend to stick with the patient tissue rather than the cadaver tissue. Everybody's a little different. However, let me show you how this is done, because this is done quite a bit in our office and all over the world. The first incision is a full thickness, and it's done by blunt dissection down to this mucogingival junction. It can be done with an elevator, even done with the scalpel right down to that. Then after the mucogingival junction is a split thickness. Now this is all done within the sulcus. We're leaving the tip of the papilla intact at all times. Here it is, a little hard to show you as we do it, but if you can imagine, these tips of this papilla are completely intact. There's no flap, just like we showed before, that's released. These are all intact, and then what we'll do is we'll slip in, and this is what you can see here. This is actually the cadaver tissue right here. It's one piece that is weaved in underneath the papilla, sutured into place to stabilize. Now sometimes we'll do a combination. We'll do the cadaver tissue with some connective tissue from the patient. Sometimes we'll do a tunnel technique with a release. There's a lot of different options here, which is great. Again, the cadaver tissue, in this case was Alloderm, sutured into place. And then with sling mattress sutures, we'll bring the released tissue over the top of our graft. So this is day of. 1 week later, we can take out these stitches. You can see we've got a great zone, starting to be a great zone, good healing. You really need to absolutely make sure that the cadaver tissue is completely coming up as well. Here it is 2 weeks later, starting to stabilize a little bit. Again, here's our before, pre-op, and our post-op. Two things have happened. We've covered up the recession of these teeth. More important, what we like to see is this thick, healthy, keratinized tissue in this area. It looks great. And again, this will be a long-term result for the patient as well. Last two cases I want to talk about as we finish up here. This and these both are regarding implants and soft tissue management. I want to show you this case in particular. This, if you look, this almost could be an after picture of a connective tissue graft. If you look, and she never had any grafting done, but you can see how healthy and thick the tissue is around tooth number 9. Boy, we've got healthy papilla. We've got a great zone. I don't even think we got the mucogingival junction that's above the lip there. This could not look any better. For our purpose today, I want to emphasize, and we're going to talk about how we're going to maintain this good, healthy surrounding gingival tissue. Now, unfortunately, we look close at the tooth number 9. She was 26 in this picture. The patient was. When she was 14, 15, she was bumped in the on the trapeze bar or playground equipment, and a hygienist recently was probing and found deep internal resorption on this tooth, external resorption. Sorry, this tooth was non-vital and resorbing, and unfortunately needed to come out. If you look close, you can see the large composite filling that was placed on this tooth back when she was a teenager. Tooth needs to come out, but we want to support and maintain this great papilla here. So this is how, there's a lot of different ways to atraumatically, gently remove this tooth. This is how we elected to do it. We cut off the crown, the coronal portion of the tooth, and then we like to split the root right in half. Well, what this then allows us to do is to pinch these two pieces of tooth together, collapse them. We call it implode it rather than explode it. I don't want to use a lot of muscle here to take this tooth out because of the fragile nature of the soft tissue and of that buccal plate, that we don't want to lose that bone. So the tooth is taken out gently and atraumatically. With around a probe, we can verify that the buccal plate is intact. We've got good, healthy papilla, and you can see where we're going with this conversation. If we were just to allow this to heal up and then place an implant in 3 to 4 months, we would lose this papilla. We would absolutely lose that papilla. So what we're going to elect to do, and I'll show you how we do this really quickly, is we'll do the immediate implant in order to maintain the soft tissue profile, the papilla and then the buccal tissue. A lot of different implant placement protocols out there. This is what we like to use. First, we'll start with a 2-millimeter twist drill to prepare the implant site. Again, the implant will be just a bit longer, more apical than the natural tooth was. We then like to establish a healthy diameter of the implant to support the soft tissue as well. If you get one a little bit too narrow, you can have the papilla collapse in on you. If you get it too wide, you'll push it out and can lose some of that contour. Well, we thought the 3.5 was a little too small. Went up to the 4.3 millimeters to further expand that. We elected to keep the 5.0 millimeter in this area due to stability, and we like the emergent profile of the future implant here. Here's the implant getting ready to go in. What I'd like you to notice here as we're placing it, this notch to the tip of the implant is 3 millimeters. So when we go to probe this down the line, we're going to get a 3-millimeter pocket. Very, very happy with that. Here's the implant going into place. There's our mark, if you will. So if you can imagine, the implant's 3 millimeters underneath that mark, placed in bone. Here it is. Now, if you were to go back to our slide when we had sectioned the coronal aspect of that tooth, it was the same shape and size of this implant. Now, this implant will support the papilla on either side and also that buccal tissue. Now, at this point, you could put a cover screw on top of it or a healing abutment, but we're afraid that this papilla would then collapse if you had them wear a flipper or an Essex retainer or some kind of temporary kind of appliance here. So what we like to do is we will then do an immediate provisional tooth, screw retained in this area. Let me show you how we do that. The implant company that we use gives us stock abutments. Obviously, they're a little too big. This is a guide pin that is inserted inside the stock abutment, and that's screwed into place. What we'll do, we've trimmed the abutment to appropriate height. Again, here's the guide pin that is screwed into place. Previously, we took an impression of the tooth when it was intact. So this will be our negative, if you will, for our future temporary. Any type of provisional material can be used here. Here it is in its raw form. We fill that impression material up. Again, the guide pin gives us a shaft to use, so we can prepare a screw retained provisional. There it is, again, in its raw form. Here it is, we've adjusted the crown, cleaned it up a little bit, and now it is being screwed into place. Again, the screw is your typical implant screw. It's screwed into place. Then we'll put a little Teflon tape or cotton. A lot of different foam can be put on top of it, and then we'll seal up that little access hole, the shaft hole, if you will, the access, which looks kind of like an endodontic access hole, digital flowable composite. So in a couple of months, when this implant is then integrated, great, you can go in and take this crown off and then do your impressions. Again, what I want you to notice more than anything, not our temporary, but I want you to know how this temporary crown is going to support the papilla and the buccal tissue in an aesthetic way. Again, here it is the same day. This is the same day that we took the tooth out, placed the implant, and did a temporary. We've retained the papilla. We've got good, healthy buccal tissue. Here's the sorry for the sideways x-ray. There's the implant, the abutment. Here's our shaft. Again, here's 1 week later. A little swollen again from impressions and us manipulating that tissue. Just chip the papilla to make it look a little more natural like your other ones. Or chip the temporary, looks just like all your other teeth here. But anyways, another thing I should mention, maybe obvious, but this provisional is what we call a party tooth. It is not, it's just meant to look good. This is a tooth that has been taken out of occlusion. We check the occlusion when it's placed, that make sure that there's no forces hitting this tooth as the implant is integrating. Explain to the patient as well that it's a little shorter. But really what we're hoping for, obviously they don't have to wear a flipper, but more important, again, we're maintaining this tissue. Here it is 6 weeks later. Here's the before, again, her natural tooth with that great healthy papilla that we noticed. Here is the after, again, in the temporary, healthy, thick. Again, after typically about 3 to 4 months of healing, the temporary can then be taken off, good healthy papilla, and a permanent crown can then be placed here, and you send it off to the lab, and the lab does its job with porcelain and shading and shape. And so here's our before and our after. Here's our natural tooth. Here's our crown. What I want you to appreciate, and what we all need to do, is maintain this good gum tissue. If you don't have enough good gum tissue, then build it up, just like we talked about, whether it would be with a connective tissue graft or a bone graft, a lot of things if you've lost a tooth for an infection. Again, this patient needed the tooth out but did not have an apical infection, had good healthy tissue, we wanted to keep it. So again, maintain that soft tissue. That's the most important, especially for implant aesthetic results. Last little tiny tidbit before we finish up here. Again, appreciate your patience with this lecture. When an implant is placed, most likely the implant will be buried under the gum tissue. What I want to show you, just a little nugget, a little pearl of wisdom, if you will, to finish up our lecture. This is an area that an implant was placed. Previously, it had a bone graft to augment the ridge. We did a connective tissue graft to augment this ridge. Now we're ready to uncover. There's an implant hiding under this tissue. Many times what we do when we uncover it, we'll just take a little tissue punch and actually take tissue away, cut it away. We don't want that to happen in this area. This is an aesthetic zone. So just a little pearl, when you go to uncover your implants, instead of taking tissue away in the anterior region, make one straight incision on the palate and move that tissue forward before placing a healing abutment. It's almost like you did a connective tissue graft without going to the roof of the mouth. Again, just a little palatal incision, move all that tissue forward, push it forward, get your healing abutment and or your temporary crown at this point in the area to help this tissue form help form papilla and a nice buccal emergence profile. Just to complete this case for you, here's the x-ray, and then here's the final result with the crown on it. And what we like to see more than anything here, we've got good, healthy, keratinized tissue on the buccal aspect of this tooth, just like we did on our natural tooth. Big picture, again, I'll say it again, if you don't have good, healthy gum tissue, keratinized attached gum tissue, go get some, whether it be through a cadaver graft, a connective tissue graft, free gingival graft. Make sure your patient have those. If you do have it, don't lose it. Maintain it. Most important thing. Well, I sure appreciate this opportunity. I want to thank the UDA for this opportunity to give this lecture, and to thank you for listening as well. I hope this was beneficial. Please feel free to reach out to me with any questions or concerns. Again, my name is Dr. Jeremy Manwaring, and I work here in Salt Lake City, Utah, and Park City at Redwood Periodontics. Have a great day.